joining. So I just want to say good afternoon and welcome to the Trinity Health Mid-Atlantic Specialty Spotlights featuring Dr. Martin Ross. This afternoon, Dr. Ross will present to you trends in orthopedic care and aftercare of hip fractures. For attending this live presentation, any physicians, nurses, PAs, social workers, pharmacists, or psychologists can apply for 1 CME credit today. The event link and ID are on slide 2 of Dr. Ross's presentation. We have also attached a job aid to this meeting request for any further instructions that you may need. So to receive a full credit for today, you must also have your full name and credentials on our attendee list, which will be submitted to our continuing education program coordinator. So if you want to use the chat feature to send us that information if it doesn't pop up on the screen. Also, today's presentation will be recorded and placed on our website for educational purposes. Now I'm turning it over to Stephanie Mills-Taylor, who is our Physician Relations Consultant for St. Mary Medical Center, and she will now introduce Dr. Ross. Thank you, Stephanie.
Thank you. Thank you, Dr. Ross. All right, Dr. Ross received his medical degree from State of New York School of Medicine in Buffalo, New York. He completed his residency at Maimonides Medical Center in Brooklyn, New York, and is board certified in orthopedic surgery. He served as Senior Medical Director of Periarticular Services, Chief of Orthopedics, and Chair of the Surgical Services Leadership Council at Penn State Health, St. Joseph in Reading, Pennsylvania. As a general orthopedic surgeon with subspecialty interests in fractures and dislocations, arthroscopy, and arthroplasty, Dr. Ross brings more than 30 years of expertise in orthopedic surgery to Mercy Catholic Medical Center. He cares for patients at Mercy Orthopedics in Darby, and that is located at 1503 Lansdowne Avenue. And I hear that you have 3 daughters. Your middle one is getting married next month, and your youngest is starting her senior year at Lafayette. So congratulations.
Thank you. Thank you. So, well, I was thinking about what kind of a presentation would be relevant from an orthopedic perspective to primary care. And one of the things that I deal with very frequently in my practice over the years has been hip fractures. And clearly, vast majority, if not all of these patients, wind up in a PCP's office shortly after their injuries. So I thought this would be a relevant topic. The slide deck, is that something that I should be bringing up, or does someone else have it there?
Yes, Doctor, if you want to bring it up and advance your slides, or I could bring it up and advance your slides, whatever you would like to do.
Okay. You might find it faster than I do.
Okay, no problem. Let me pull that up for you. All right, so. One second.
Mm-hmm.
Share content. Here we go. All right. So, can you see my screen?
It's there.
All right. Great.
And now we have a schedule of some sort.
Yeah. So what this is our disclosure for our program. That just tells you who's on the committee and that you are part of the faculty today because you're presenting. Slide 2 will give us the date of today and the event number that people will need to use for their CME credit. And then I'm going to just click over to your slide, your first slide, and you may begin. Thank you, Doctor.
Okay, well, I sort of spoke through this one already, so next slide, please.
Okay.
So the majority of the patients that we see with hip fractures fall into the elderly, frail group with usually multiple medical comorbidities. Femur is not a little bone. It's not easy to break it, but as you get older and coordination starts to fail, you see these things happening more and more frequently. And there is significant trouble that comes from these fractures. Next slide. There was a study done in 2011, published in the Archives of Internal Medicine, that compared a cohort of over 1,000 women with broken hips versus controls. And the significant findings they had were they had lower BMIs and as well as lower bone mineral densities. But how significant the cigarette smoke exposure is, hard to say. And many of these patients are thin. Many of them are typically the Northern European background. The significant findings as a result of this study, though, was that the mortality rate in the first year after this injury was double the control group. And I thought what was even more curious was that if you looked at the group between 65 and 70, their mortality rate was 5 times their matched group. That rate dropped down in people in their 70s, but those over 80, mortality rate did not increase, or at least it could not be found as an increase. Now, if you look at why these injuries are occurring, in general hip fractures, you can divide them up into high energy, low energy injuries and those acute injuries. We're really focusing on these low energy injuries where about 90% or more of these fractures occur in people over the age of 50. Most of these are falls from standing height, sometimes out of a chair. Sometimes it's a little mixed in terms of whether it truly is a trauma. People knocked over by a bike or tripped over a curb, things like that. Also included in this low energy group would be pathologic fractures where the bone has been weakened. It's also a common thing to see. You could argue as to whether or not all of these fractures are pathologic from the point of view of osteopenia as a pathologic process, resulting in them being at high risk for fracture. We're sort of setting aside those high energy injuries, the motor vehicle accidents, the gunshot wounds. But there's another subgroup of stress fractures, which occur through a fairly broad age range as people change activity. And then there are the atypical fractures, which are the ones that may come across in a primary care setting as just the hip pain, mostly patients that are on bisphosphonate, where they'll get an atypical presentation of proximal femoral, whether you want to call it a stress fracture, but they will get an atypical fracture that doesn't follow the normal hip fracture patterns that comes from an oversuppression of the bone remodeling by the bisphosphonates. They most often will have pain for an extended period of weeks before they actually fracture. So it's one of those things that if they're complaining of pain, you got to get the x-ray, and the x-ray will be fairly typical for an ongoing stress reaction in that area. As I was saying, most of these that we're looking at, the low energies, fall from standing height, geriatric kinds of hip fractures. They often have multiple medical comorbidities. If you look at the actual incidence, they're reporting out, this was out of the American Academy of Orthopedic Surgery review, and over 300,000 per year. That is expected to grow to over 500,000 per year in the next 10, 20 years. When you look at the actual incidence, I mean, if you take rough numbers, that's about 1 in 1,000 in the population that are falling and breaking their hips. And that's a fairly high incidence. Obvious implications worldwide, but that's just in the United States. Next slide. So the other significant part of this is that, in the prior slide, we talked about mortality rates in about the 16–17% range. Some studies have the mortality rate upwards of 33% within the first year of fracture. The significant factors that we have that we can look to determine whether we're doing a good job for these people, whether we're helping them as best can be helped, include indices like time to surgery, the length of hospital stay, the actual post-operative mortality rates, and readmission rates. Those are the things that are measurable, that we can get a sense of how well we're doing with our care. Next slide. There are some standardized programs out there that have been established in tertiary centers, and they've looked to see what setting up a good, solid program, multidisciplinary approach to treatment, what that does for these patients. And what they found is that when you set up these kinds of programs, the incidence of DVT is lowered by about half, and patients' adherence to prophylaxis postoperatively is improved. And that's where a lot of the outpatient follow-up becomes key and critical. We'll see them in the office, we'll ask them, but a lot of times it's the primary care posing the same questions to them about their compliance that makes a difference. The actual treatment for their osteopenia, though, is something that was found to be substantially improved by having this kind of a multidisciplinary approach. Orthopedists are notoriously bad at talking with patients about what their osteopenia, osteoporosis means, and the implications of starting on medical therapy for those conditions. Unfortunately, the other issues that come with hip fractures in terms of other morbidities and the mortality rates were not affected by establishing this kind of program. Next slide. So the care delivery models, if you look back on the classic approach to it, these patients were always admitted to orthopedics. We invariably obtained a medical consult, if not a cardiology consult on top. I go back far enough to remember the days where all of the medical consults were private practitioners who had to come in from their office to see the patient, which always delayed them getting to the OR and any testing that needed to be done. And very commonly, they weren't in the hospital every day, so they didn't see the patient every day necessarily. So we were, sort of driving the bus there pretty independently. Next round of treatment option, or the protocols that were established, had these patients admitted to medical units, geriatric units. Ortho would be consulted. They'd do their surgery and then often would disappear. Medical care was better, clearly, but a lot of the issues that were orthopedic would fall by the wayside when we weren't seeing them on a regular and consistent basis. Of late, there's these shared responsibilities, shared care, these programs that are establishing these kinds of multidisciplinary care approaches have both teams consistently seeing the patient from admission to discharge and then followed up in the office. And this seems to be providing the best overall outcomes for the patient. Next slide. So here we have a certain number of goals, and we have set up a certain amount of a standardized program. Patients are admitted to hospitalist service. We try to get them optimized preoperatively with the hospitalist directly involved, calling consultations as they feel appropriate. We're trying to get these patients to the operating room within 24 hours unless they're either anticoagulated or their comorbidities preclude safe transition to the operating room in that type of time frame. Additionally, we're trying to mobilize these patients out of bed, if not immediately day of surgery, the first day after surgery. You could ask, why are we so aggressive in the way we treat these patients? And often families will ask this more often than anybody else. There's an article out of the Journal of Orthopedic Trauma that basically showed what happens when comparing operative and non-operative treatment of hip fractures. They had a fairly large cohort of non-operatively cared for patients and showed that mortality was substantially higher in those patients treated non-operatively during their initial treatment, during 30-day follow-up, and at a year. They looked at life expectancy after fracture, and they showed that those people treated non-operatively had a substantially shorter life expectancy. So with those kinds of numbers, it's kind of hard to recommend non-operative care except for those patients that are truly premorbid or close to mortality. So we do tend to be very aggressive. Now, you could argue there was likely a significant selection bias in this study. Those being treated non-operatively tend to be sicker, already multiple medical comorbidities. But a certain number of these are people that just opt for non-operative care. Next slide. So if we look at the types of fractures, we generally divide these up into extracapsular and intracapsular fractures. Intracapsular are the subcapital fractures. For the most part, that's what we're looking at in these kinds of falls, as opposed to the intertrochanteric and subtrochanteric fractures. The significance is that we treat them differently. Recovery is different. There are implications relative to activity after repair. And most of that comes from the significance of blood supply. The head of the femur is intracapsular, and its blood supply is completely intraosseous. So if all the blood is coming through the bone and you fracture the bone, you're losing blood supply to that femoral head. So whenever a fracture is displaced, you have to assume there's a substantial amount of interruption of blood flow. And that does make a significant difference in how we approach these. Intertrochanteric fractures and subtrochanteric fractures, it's anatomic level. There are some differences in healing. There are some differences in weight bearing, but the actual operative approach is very similar between the two. Next slide. So here are two x-rays. On the left is arguably an intertroch extending into the subtroch region. On the right is a fairly typical intertrochanteric fracture. And the issue is, what do we do with these things? On the next slide. So these are two of the most common approaches to treatment. On the left, you have a sliding hip screw, whether there's 2 screws in the bottom or 4 screws in the bottom. Standard plate with a fairly large bolt that goes into the head to hold position and reduction. That was the standard of care 30+ years ago when I started. About 10 years later, we started seeing what you see on the right, which is a nail or a rod used for hip fractures. They've gone through significant modifications and advancements in how they work, and you'll get into different docs like different approaches. Some rod everything, some plate everything. There are reasons why some like some over the others. I remember as a resident, when we would go in to put a plate on, there was always some towels or pads on the floor because these were a bloody mess. The amount of blood loss was substantial. Post-operative transfusion rates were fairly high. Incisions were only about 4 or 5 inches long, but with all that, the bleeding was substantial. Cutting through muscle in order to get down to where you needed to get to put the hardware in place. When you put in the rod on the right, you have a 1-inch incision at the very top above the tip of the rod. There's another 1/2-inch incision in the middle, mostly mid-thigh where the bolt goes through. And you talk about a 1 centimeter incision down if you're putting a locking screw in. Many times we'll use a long rod without a locking screw, so you only have the 2 small incisions. Blood loss is substantially lower in those situations. Operative time, I believe, is shorter. There have been studies that looked at comparing these two approaches. The rods cost a lot more money than the plate and screw does. That's balanced out somewhat by a shorter operative time, lower blood loss, easier care for the patient. And then there's those that have shown in some studies that the actual cost of the implant, while it's higher compared to the overall episode of care, does not add substantially to the overall cost. So there's a little bit of a dealer's choice in this. There are some fractures, particularly subtroch fractures, where a rod is clearly the better approach to treatment, and that probably will always be. So if you look at subcapital fractures, little tough to see here. There is a white line on the left hip that is running across. That is a non-displaced or impacted femoral neck. Much more obvious on the right image is a displaced subcapital fracture. There is a significant difference in what we do for these two situations. The first thing that goes into deciding how to treat these is based on the patient's age and general condition. The typical treatment for the injury on the left, if you go to the next slide, is simply at most 1-inch incision with placement of 3 screws across the fracture to hold it in place. The goal again is weight bearing immediately, and that sometimes is difficult to achieve. We worry about the fracture displacing, but in those that are non-displaced to begin with, those that are impacted to begin with, 3 screws like this will tend to hold the fracture in good position and allow for healing without further consequence. Because of that fracture across the neck, we're always worried about avascular necrosis. We worry about poor blood supply resulting in non-union as well. And there is an incidence of non-union and AVN in these situations, even in a non-displaced fracture. The next slide. In these situations, we commonly wind up reverting to arthroplasty for treatment. There are exceptions to that, particularly based on the age and activity level of the individual. In order to treat that fracture with the pins like we did the other one, you're talking about having someone non-weight bearing for the better part of 6 or 8 weeks. Most of the elderly people that are coming in with that injury will not tolerate that degree of immobility. They will decondition severely, they will become sick. And that's why we'll most commonly look to do a hemiarthroplasty or a total hip arthroplasty on these patients in order to advance their activity, get them up and walking the day after surgery. The problem with pinning a fracture like this is that you have an incidence of non-union and avascular necrosis that runs upwards of about 30%. So you'd be taking these elderly patients with multiple comorbidities back to the operating room 1 in 3 times to convert them to a total joint. And it was felt that studies suggest that arthroplasty is a better way to approach it, and we'll do more of them more good. Next slide. So why even think about pinning these? Well, you know, pinning is such a small incision, it's minimal blood loss. It really, in those situations, you can sit on the fence deciding whether or not the patient would be better off with a pinning as opposed to a replacement. And that's really the key to it. Next slide. So we're doing replacements mostly for displaced fractures. It is a longer surgery. There is a significant blood loss associated with it. And after the operation, you're not dealing with your own hip anymore. The partial hip replacements do not function as well in most studies when compared to total hip arthroplasties. But the issue is, well, okay, then why just not do totals on everyone? If you go to the next slide. So the hemiarthroplasty is generally a much shorter surgery. You're only replacing the femoral head. You're not doing anything to the acetabulum. You're maintaining a native acetabulum. So therefore, you're talking about a shorter operation with less blood loss. Problem is that most studies suggest that these hemiarthroplasties will give you about 5 to 8 years. And if you look at the mortality rates and so on, that for most people would be sufficient when they sustain these kinds of injuries. The other thing is that a total hip replacement for a fracture is not the same as an elective total hip. Next slide. When you look at the comparison of people that have total hips done for hip fractures as opposed to total hip arthroplasties, you're talking about double the length of stay on average. You're talking about 3 times or greater the admission rate. And you're talking about a significantly higher cost of care for treatment of these injuries. But when you talk about someone who's in their late 60s, early 70s, who pre-injury has been active and fully functional, hemiarthroplasty may not serve them as well. And so there's a certain amount of patient selection that has to go on to determine best approach to treatment. Next slide. So what are we doing at this point that's a little different than what's been done in the past? Well, we talked a little bit about the hardware differences and how we're approaching it. I have to say that from my perspective, a lot of what we do now is what we were doing back at least 20 years ago, if not 25 or 30 years ago. Some of the things that are significantly different, we've started using the antifibrinolytics, tranexamic acid, Amicar, whether it's IV, topical, or oral, in order to reduce blood loss perioperatively for the hemiarthroplasties and the total hip arthroplasties. There have been studies that show that topically applied for about 5 minutes during surgery gives you the same effect as IV administration without systemic effect. And I think this has resulted in a substantial reduction in the transfusion rate, and there's a number of studies that prove that out. Another big area of change has been this multimodal pain management approach to treatment. There's a lot of discussion about preoperatively adequately caring for their pain and making sure they're medicated sufficiently without snowing them under and getting them completely confused. But also during the surgery itself, you talk about there's a periarticular injection solution that we are using here that's been promoted through the Mayo Clinic out in Arizona, actually. Consists of a ropivacaine, morphine, epinephrine, and tramadol. I'm sorry, toradol, in a solution of saline that's injected around the wound in order to give about a 24-hour period of relief, which is variable in terms of how well people do with that, but it clearly reduces their narcotic requirements postoperatively. There's also been a significant trend toward regional anesthesia for these kinds of injuries. What that does is it reduces the amount of blood loss to a significant degree. It reduces the incidence of DVT postoperatively. The other thing that we've been doing differently in terms of wound closures, there are various sutures now that particularly the something called Stratafix, which is a barbed suture that basically you do not need to tie knots with, that holds a wound closed as quicker closure. Using that kind of suture in a subcuticular fashion, where you're closing skin from below. There's no sutures sticking out. There's no staples in place. You seal the wound with Dermabond on top of that. And I believe that there have been enough studies that show that it reduces infection rates nicely. That's combined with something called a Mepilex dressing, commonly used on pressure sores and those kinds of issues, Some of them are silver impregnated, and they are left in place for upwards of 7 to 10 days, keeping that sealed system of wound closure from the bacteria that surrounds them, in whether it's a hospital setting or the extended care facility setting. And that combination of factors has improved overall care and outcomes for people with hip fractures. So with that, any questions?
Let's see, we'll check the chat. There is a couple questions out here, about 5. Doctor, what additional medical evaluation treatment should be considered for these patients?
Well, one of the common problems we get into is we have a patient admitted, they're seen by the hospitalist service, and there's often the consideration of, do you or don't you need cardiology to take a look at these folks before surgery? I think that's probably one of the most common issues that comes up. I mean, there are clearly people with sufficient cardiac issues that you need the cardiology consult, but there's a lot of those patients, they're older, they may or may not have had medical care. Classically, obtaining the cardiology consult delays their ability to get to the operating room, at least by a few hours, if not a day. We get back and forth in terms of, do they need an echo? Will an echo change anything? These are people that do have significant risk for post-operative issues, and the longer they sit, the sicker they get. So, I think that's probably one of the biggest areas of concern.
Okay, another question is a 2-part question. How long do you recommend DVT prophylaxis after surgery, and what is the preferred prophylaxis?
A lot of this depends on how quickly a patient gets up and what exactly they had done. Unlike total hips, where the trend has been, at least from the orthopedic standpoint, going to aspirin in those patients without significant risk factors, the hip fractures, basically by definition, are high risk. So we're using, whether it's a Lovenox or a novel oral anticoagulant, they're all being treated. They're all being treated for at least 4 weeks, if not 6 weeks, depending on how quickly they get up and moving. In a pinning, you will typically see these people will often get up and get back to their normal activity level within a couple of weeks, and then you could argue as to whether or not they still need to be prophylaxed further.
Okay. This is another question. How are Fosamax fractures a significant concern, and are they treated any differently?
So these Fosamax fractures, the bisphosphonate atypical fractures, the concern to my mind is that they are somewhat insidious in how they present themselves. There are those that just come in, they had a fall and they broke, but a lot of these patients that I've seen are coming in with a 2-3 month history of thigh pain, non-specific. It's not that they're particularly tender, they've just been aching. Some of them have seen their primary care docs, some of them have had x-rays. Sometimes the changes on x-ray are recognized, sometimes they're not. The significance comes in that if you catch these prior to fracture, you at least have a chance of doing things that perhaps save them from a surgical treatment. If you can get them non-weight bearing or limited weight bearing, generally stop the bisphosphonate to allow a more normal bone metabolism to occur. I mean, this falls into the whole discussion of these hiatuses for people on bisphosphonates. When they're taking them for 3, 4, 5 years, there should be some period of at least a few months where they're off these medications. And I think that from a primary care standpoint is the major lesson in these fractures.
Okay, I have 2 more questions. Is there a typical impact on functional status after a hip fracture?
So most of these patients will suffer as a result of their injury. Many of them become very, it's almost a post-traumatic stress disorder. Their fear of falling is phenomenal. classic, or typically what we'll see is that people will lose a bit of their edge. Those people that were ambulating independently often will wind up with a cane. Those that were walking with a cane often wind up with a walker. And unfortunately, it's not uncommon where someone who was on a walker before will wind up wheelchair bound or bed bound as a result of their injury, even with appropriate surgical care in a timely fashion.
And the last question I see here is, what age is considered young versus elderly when discussing a hip fracture?
Yeah, the older I get, the older that number becomes. But, you know, the typical discussion is around the age of 65 often separates things out. But clearly people in their 50s with a displaced subcapital fracture will be pinned. Typically people over the age of 65 will have a hemiarthroplasty or a total hip arthroplasty, depending on their other issues. It's that in-between gray zone, you know, people in their late 50s, early 60s that may not be as healthy or as active, and what the best approach is for them given the risks involved in not replacing and the difficulties that they'll see post-operatively if you just pin them.
Okay. And that is the last question I see in chat. Is there any more questions for Dr. Ross? Okay. Well, thank you, Dr. Ross, for your great presentation today. We really learned a lot. We appreciate it. Thank you.
Yeah,
Thank you for inviting me.
All right. Have a wonderful day, everybody. Take care.
Thank you too.
Bye-bye.